Okay, let's unpack this. Have you ever really thought about the incredible engineering happening inside your chest with every single breath? It's more than just air moving in and out. It's a meticulously balanced system of pressures, volumes, and elastic forces constantly at work.
And to truly master how we breathe, and crucially, what goes wrong in many lung diseases, we get to go deep into what's known as lung mechanics. Our goal for this deep dive is to build your foundational understanding, the kind of detailed knowledge that the elite professionals in this field rely on.
Absolutely. Today, our deep dive is into static lung and chest wall mechanics. We've gathered a detailed stack of sources that lay out the core principles, how air moves in and out, why specific lung volumes are measured, and the crucial roles of fascinating elements like, well, lung compliance and pulmonary surfactant. Our mission is to distill these complex physiological concepts into clear, actionable insights, giving you a deep mastery of this vital information. So to really understand how we breathe, let's start with the fundamental blueprint, lung mechanics. At its heart, it's the study of the mechanical properties of your lungs and the chest wall.
Right, and when we say chest wall, we're talking about more than just your ribs. It also includes your diaphragm, the abdominal cavity, and those muscles in your anterior abdomen. Knowing these components is vital because most lung diseases directly impact these mechanical properties, fundamentally changing how your system works.
That's a powerful and sobering detail, actually. It highlights why respiratory muscle fatigue, the point where these muscles simply can't overcome altered mechanics anymore, is a common cause of death in lung disease. It's like a constant battle against resistance. Now, for our deep dive today, we're zeroing in on static mechanics. That's when lung volume isn't changing over time.
Exactly.
Yeah.
There's also dynamic mechanics, where volume is actively changing, but we'll save that deeper dive for another time.
Okay.
So, in a healthy person, your lungs and chest wall work together as a perfectly synchronized unit. Between them is a tiny area called the pleural space. It's really just a potential space with a thin layer of fluid. The key takeaway here is that any change in lung volume is ultimately driven by changes in the pressure surrounding these structures.
Right. Pressure changes drive volume changes. And to really understand that, we need to get clear on the three main pressures at play in your respiratory system. First, there's alveolar pressure, or PA, which is the pressure of the air inside the air sacs of your lung, the alveoli. Then we have pleural pressure, PPL. That's the pressure in that tiny pleural space surrounding the lung. And finally, atmospheric or barometric pressure, PD, which is the air pressure all around us on the outside, and it serves as our baseline, our reference point, usually considered 0 for comparison.
Now, here's where these pressures get interesting. They work together through what we call transmural pressures. Think of transmural as simply the pressure difference across a wall or surface. Like imagine blowing up a balloon.
Okay.
The pressure inside the balloon compared to the pressure outside is its transmural pressure. That's what makes it inflate or deflate. For your lung, this is the transpulmonary or transluminal pressure, PL. It's the pressure difference across the lung itself. Alveolar pressure minus pleural pressure. So PL equals PA minus PPL.
Got it. PA minus PPL. Then we have the pressure across your chest wall, or PLV. This is the difference between the pleural pressure, which is inside that space, and the atmospheric pressure outside your body. So PW equals PPL minus PLO, the outside pressure.
Exactly. And if we combine these, the pressure across your entire respiratory system, PRS, is simply the sum of the pressure across your lung and the pressure across your chest wall. So PRS equals PL plus POA. But if you substitute the definitions we just covered, it beautifully simplifies to PRS equals PA minus P.
So the pressure for the whole system is just the inside alveolar pressure minus the outside atmospheric pressure.
Precisely. What this elegant relationship tells us is that the pressure driving air into or out of your entire system is really just the difference between the air pressure inside your lungs and the air pressure outside your body. It shows how the whole system is interconnected.
Okay, so we've defined these pressures, but how do they actually make air move into and out of your lungs? What's the fundamental principle at play here?
It all comes down to a simple universal rule. Air, or any gas, always flows from an area of higher pressure to an area of lower pressure. Always. If there's no pressure difference, no gradient, there's no airflow. So let me ask you, if there's no airflow at the very end of breathing in or at the very end of breathing out, what does that tell us about the pressure inside your lungs compared to the outside air?
Okay, if air isn't moving, then the pressure inside the lungs, that alveolar pressure PA, must be exactly the same as the atmospheric pressure outside PB. They must be equal. Otherwise, air would still be rushing in or out. That zero pressure gradient is key, right?
Precisely. That's a critical insight for mastering this. But here's a fascinating detail. Even when alveolar pressure matches atmospheric pressure, your pleural pressure, ppl, is not zero. In fact, before you even take a breath, at the end of a normal exhale, it's typically negative, around -3 to -5 centimeters of water relative to atmospheric.
Negative. Why negative?
Well, this negative pressure is actually created by your lung's own inward elastic recoil. The lung tissue naturally wants to shrink, pulling away from the chest wall. It's like a constant, subtle tug-of-war happening in that pleural space.
That makes perfect sense. So let's talk about how we actually start that inward rush of air. Inspiration is an active process, right? You're contracting muscles.
Exactly. It kicks off with the contraction of your inspiratory muscles, primarily the diaphragm, but also some intercostal muscles. As the diaphragm moves down and your chest wall expands, the pleural pressure decreases, becoming even more negative. This creates a stronger pull.
And that increasing negative pleural pressure then gets transmitted across your lung tissue, causing the alveolar pressure, PA, to drop below atmospheric pressure. As long as your glottis is open, air rushes into your airways and alveoli. It's like a vacuum effect, pulling air in.
And here's a subtle but important point for those looking to master this. The drop in pleural pressure at the start of inspiration is actually greater than the resulting fall in alveolar pressure. This creates a positive transpulmonary pressure, PL, which is absolutely essential for increasing lung volume. Think of it like this. The more the transpulmonary pressure increases, the more lung volume you gain. It's a direct and powerful relationship.
So PL has to be positive to inflate the lung?
Yes. And during this, your chest wall expands, and its transmural pressure, PW, remains negative during quiet breathing because your pleural pressure is still negative relative to the outside atmospheric pressure.
Okay, so we've activated those muscles, pulled in the air, and filled the lungs. What happens when we relax? Does exhalation require the same kind of effort, or is it a different story altogether?
During quiet breathing, exhalation is generally a passive process. No active muscle contraction needed. Your diaphragm simply relaxes and moves higher up into the chest. As that happens, pleural pressure becomes less negative. It actually increases, moving closer to zero. This makes your alveolar pressure, PA, become positive, rising above atmospheric pressure. And just like we said, gas then flows out from that higher alveolar pressure to the lower atmospheric pressure outside your body.
So the driving force for exhalation is essentially the natural tendency of your lungs to recoil, combined with that increasing pleural pressure. And I imagine the initial pressure change isn't huge during quiet breathing.
Exactly. The driving force for exhalation in the alveoli is the sum of the elastic recoil of the lungs and the pleural pressure. You're right, the initial decrease in alveolar pressure during quiet inspiration is quite small, typically only 1 to 3 centimeters of water difference from atmospheric. But here's a crucial clinical insight. In individuals with airway obstruction, that pressure drop needed to get air in becomes much, much larger. They have to work harder.
That makes sense.
And just like with inspiration, airflow stops precisely when alveolar pressure equals atmospheric pressure, again indicating that pressure gradient is gone. Back to zero difference.
It's incredible to visualize these changes. Imagine a graph where you can see the alveolar and pleural pressure fluctuating throughout quiet breathing. You'd see the pressures dip negative during inspiration, pulling air in, then become positive during exhalation, pushing air out. And at the moments of no airflow, like point A at end exhalation and point C at end inspiration on that classic graph, the alveolar pressure would be right back at zero, matching atmospheric pressure. It's a dynamic yet perfectly balanced dance.
It really is.
Okay, beyond the subtle dance of pressures, the actual physical architecture of your lungs, specifically its volumes and capacities, are absolutely crucial to understanding lung mechanics. And here's why it matters. Many diseases can significantly alter these volumes, massively increasing the effort it takes just to breathe.
Definitely. And every single lung volume you have is a piece of the puzzle that makes up your total lung capacity, or TLC. That's the total amount of air your lungs can hold after you've taken the deepest possible breath you can manage. And within that TLC, we identify 4 distinct lung volumes.
Let's unpack those. First, there's your tidal volume, or V. That's the amount of air you move in and out with each quiet breath, usually around, what, half a liter?
About that, yeah. 500 milliliters typical.
It's barely noticeable, isn't it? It's like the background hum of breathing.
Then, the inspiratory reserve volume, IRV, is the extra amount of air you can still inhale after a normal tidal breath. Your reserve, for when you need more air, like when you're exuding yourself or taking a deep sigh.
Right, it's the volume above your normal breath in.
And the expiratory reserve volume, ERV, is the extra air you can force out after a normal tidal exhalation, similarly used for increased effort, like blowing out candles. And finally, the residual volume, RV, is the stubborn bit of air that always remains in your lungs, even after you've pushed out as much as you possibly can. You can't fully empty them. That's right, that air stays trapped. Now, when we talk about a lung capacity, we're referring to the sum of two or more of these individual volumes. For instance, your vital capacity, VC, is the total air you can exhale from maximal inspiration down to maximal exhalation, combining your tidal volume, inspiratory reserve volume, and expiratory reserve volume.
So VC is like your usable range of air.
You could think of it that way, yes.
Yeah.
Your total lung capacity, TLC, as we mentioned, is the grand total, summing up your vital capacity and that residual volume, typically around 6 liters for an average adult male, maybe a bit less for females.
6 liters, wow.
And a particularly important one for diagnostics is the functional residual capacity, FRC. This is the volume of air left in your lungs at the end of a normal, quiet exhalation, usually around 2.4 liters. Think of it as your lungs' natural resting point, the equilibrium point between breaths.
Okay, FRC, the end of a normal breath out. So how do experts actually measure these vital numbers? Most of these volumes and capacities can be measured using a device called a spirometer, right?
Correct. Spirometry is the most common pulmonary function test.
You breathe into it, and it measures the air movement. Tidal volume is straightforward. You just breathe normally into the machine. To measure vital capacity, you take a maximal inhalation and then exhale as forcefully and completely as you can till there's no more air coming out. ERV can then be calculated from those maneuvers, maybe by measuring from the end of a normal tidal breath down to maximal exhalation.
Yes, that's how ERV is determined.
But here's a critical detail and maybe a challenge. The residual volume, RV, cannot be measured by a spirometer. Why? Because it's the air that remains in your lungs after a maximal exhalation, so it simply can't be exhaled into the device.
Exactly. You can't blow out what's left behind. This leads us to a crucial challenge. How do you measure that trapped residual volume and consequently the total lung capacity, which includes RV? For this, we turn to more sophisticated techniques, helium dilution and body plethysmography. The helium dilution technique is older and generally simpler, but it often gives us less accurate results, particularly in certain diseases.
Okay, helium dilution, how does that work?
With helium dilution, you're essentially using an inert gas, like helium, which doesn't get absorbed by the blood. You know the starting concentration, let's call it C1, and the starting volume of the spirometer system, V1. You then have the patient breathe this mixture, connecting the spirometer to their lungs, which have an unknown volume, V2 specifically, their FRC. After giving the helium time to spread out evenly throughout the connected spaces, you measure the new diluted concentration, C2. Then you calculate the unknown lung volume V2 using the principle C1V1 equals C2V1 plus V2. It's basically an equation based on the conservation of mass for the helium.
It's a bit like pouring a known amount of dye into an unknown volume of water and then measuring how diluted the dye becomes to figure out the water's volume. Clever.
It is. But here's a key insight for understanding the limitations of this method, especially for elite professionals. Helium dilution only measures the gas volume that can freely communicate with the airways, the volume the helium can actually mix into.
Ah, okay. So if there's air trapped somewhere the helium can't reach?
Exactly. If there's any air trapped in the lungs due to airway obstruction or closure, the helium won't reach it, and that trapped air won't be included in the FRC measurement. The result will underestimate the true FRC.
And that's exactly where body plethysmography, often called a body box, comes in. It's generally considered more accurate because it doesn't just measure communicating gas. In this setup, the patient sits inside an airtight box, kind of like a phone booth, and breathes through a mouthpiece connected to an airflow sensor.
Right. This technique cleverly uses Boyle's gas law, which states that if the temperature stays constant, the pressure of a gas multiplied by its volume remains constant. P times V is constant. The patient performs a panting maneuver against a temporarily closed shutter or mouthpiece. As they try to exhale against the closed shutter, the gas in their lungs compresses slightly, causing their lung volume to decrease.
Okay, so lung volume goes down.
Simultaneously, because the box is airtight, this small decrease in the patient's thoracic volume causes the volume of air in the box around them to increase slightly, which leads to a measurable fall in the box pressure. By measuring these tiny rapid changes in mouthpiece pressure, reflecting alveolar pressure, and box pressure, reflecting lung volume changes, we can precisely calculate the total volume of gas in the lungs at the start of the maneuver, the FRC.
Wow, that's ingenious. And here's the really powerful distinction between the two methods, right? The body plethysmography method measures the total volume of gas in your lungs at the end of a normal exhalation, your FRC. And yes, that absolutely includes any trapped gas, whether it's communicating with the airways or not.
That's the crucial difference. It measures all the gas within the thorax. So if a significant amount of air is trapped due to premature airway closure, perhaps an emphysema, the FRC measured by the body box will be much higher than what you'd get from helium dilution. This comparison between the two FRC measurements provides a vital diagnostic clue in the clinic about the presence and extent of gas trapping.
That makes total sense. These pulmonary function tests, then, are absolutely invaluable in clinical practice. They help diagnose abnormalities, track how diseases are progressing, and most importantly, distinguish between the two major categories of lung pathophysiology: obstructive and restrictive processes.
Exactly. For instance, in healthy individuals, the ratio of residual volume to total lung capacity, or RVTLC, is typically less than 0.25 or 25%, meaning about a quarter or less of the total air your lungs could hold usually remains in your lungs after a full exhale.
Okay.
But in obstructive lung diseases, like emphysema or chronic bronchitis, this RVTLC ratio can significantly increase. This often happens because the residual volume itself increases, sometimes dramatically, due to air trapping, often out of proportion to any change in your overall total lung capacity. On imaging, like a chest X-ray, these lungs often look hyperinflated because of all that trapped air.
Imagine trying to get a full, deep breath when your lungs are already partially inflated, like a balloon that never quite deflates. That must be exhausting. That's the constant struggle for someone with severe COPD. It explains why even small movements can leave them breathless.
It absolutely does increase the work of breathing. Now, in contrast with restrictive lung diseases, think pulmonary fibrosis or problems with the chest wall itself,
Sure.
the core problem is that the lungs or the chest simply can't expand to their normal anticipated volume. As a result, the total lung capacity, TLC, decreases. This also leads to an increase in the RV-TLC ratio, but for a very different reason, not necessarily because RV is huge, but because the total capacity, TLC, the denominator in that ratio, is now much smaller.
Ah, so the ratio goes up, but the reason is different, less overall space.
Precisely. So while the ratio might appear similarly elevated on paper in both cases, the underlying mechanical issue for the patient and the approach to treatment is fundamentally different. Understanding that distinction is absolutely key to professional diagnosis and management.
Okay, so after talking about all these volumes, what truly determines how much air your lung can hold at its maximum capacity, TLC, or how much is left at its minimum, RV? It all comes down to a fascinating push and pull between the lung tissue itself and your chest wall, right? They act as a unit.
Exactly. In a healthy person, they always move together, coupled by that negative pleural pressure. Your lung tissue is packed with elastic fibers, like tiny rubber bands, that stretch when you pull them open to breathe in, when transpulmonary pressure increases, and then passively snap back or recoil when you relax to breathe out, as transpulmonary pressure decreases.
And that recoil is pretty strong.
It's quite astonishing just how much elastic recoil your lung tissue has. If your lungs were removed from your chest, with no chest wall or pleural pressure holding them open, they'd shrink down to almost completely airless, maybe only 10% or so of their total capacity. They really want to collapse inwards. On the flip side, your chest wall also has its own elastic properties. If you imagine your chest wall without the lungs inside pulling inwards, its natural resting volume would actually expand outwards to about 60% of your total lung capacity. So the chest wall on its own actually wants to spring outwards, especially at lower lung volumes.
So the overall lung volumes we measure are really just a delicate negotiation, a balance point between the lung's powerful inward elastic recoil and the chest wall's tendency to spring outwards.
That's a perfect way to put it. Think about your total lung capacity, TLC. That maximum volume is limited by the strength of your inspiratory muscles actively pulling the system open against the increasing inward recoil of both the lung and the chest wall at high volumes. As your lung volume increases, these chest wall muscles lengthen, which actually increases their ability to generate force, boosting the outward pull.
Okay, and what about residual volume, RV?
Residual volume, the minimum air left, happens when your expiratory muscles, even contracting maximally, simply can't generate enough force to overcome the outward spring of the chest wall at very low volumes and compress the chest any further.
But the most important balance point, you said, is the functional residual capacity, FRC. That's the volume of air in your lungs at the end of a normal, quiet exhalation.
Yes, FRC is physiologically critical. At FRC, the lung's inward elastic recoil pressure, trying to make it smaller, is perfectly balanced by the chest wall's outward recoil pressure, trying to make it larger. Crucially, at FRC, your respiratory muscles are completely relaxed. It's the natural equilibrium point of the combined lung-chest wall system.
And things can shift that balance point.
Absolutely. If those chest wall muscles are weak, for example, the outward pull is less, so FRC tends to decrease. But in airway obstruction, where airways close prematurely during exhalation, FRC actually increases because air gets trapped, preventing the system from reaching its usual relaxed volume.
This balance can be beautifully represented on what we call relaxation pressure volume curves for the lung, the chest wall, and the entire respiratory system combined.
Yes, those curves are fundamental.
Yeah.
Looking at them, you'd see a point where the transmural pressure across the entire respiratory system, PRS equals PAPB, is zero. That point, by definition, is FRC. It's where the lung's inward recoil is perfectly matched by the chest wall's outward recoil, and your muscles are totally relaxed.
And what else do those curves show?
Well, they show that at total lung capacity, way up high, both the lung pressure, PL, and the chest wall pressure, PW, are positive. It requires active, positive outward pressure from muscles to keep the system distended at that maximum volume against strong inward recoil. And revisiting the chest wall's own natural resting volume, where it's transmural pressure, PW0, that happens around 60% of TLC. Below that 60%, the chest wall wants to spring outward. Above it, it starts to recoil inward, requiring more positive transmural pressure to distend it further.
Those curves also vividly illustrate the elastic limits of the lung, don't they? For a healthy lung by itself, the pressure volume curve starts to flatten out at higher pressures, maybe above 20 or 30 centimeters of water.
That's right. It tells you the lung has reached its elastic limit. Adding more pressure produces very little extra volume. The slope, which represents compliance, gets very low. It's like trying to inflate a balloon that's already stretched to its maximum. This limitation comes primarily from the lung's connective tissue framework, its collagen and elastin fibers reaching their stretch limit.
This raises an important clinical question. What happens if you apply even more pressure beyond these limits, say with aggressive mechanical ventilation?
That's when you risk serious injury. Specifically, you risk rupturing the small air sacs, the alveoli, especially those near the lung surface or in already damaged areas. Air can then escape from the lung into the pleural space, leading to a condition called a pneumothorax or a collapsed lung.
And in a pneumothorax.
In a pneumothorax, that crucial coupling between the lung and chest wall is broken because air fills the pleural space. The lungs recoil and collapse inwards until their transpulmonary pressure, PL, becomes zero, and the chest wall simultaneously expands outwards until its own trans-chest wall pressure, PW, becomes zero, reaching that 60% TLC volume. It's a fundamental breakdown of the integrated system.
It really highlights how vital that intact pleural space is. This all seems to boil down to a core relationship that's essential for mastering lung mechanics. Alveolar pressure, PA, is simply the sum of the pleural pressure, PPL, and the elastic recoil pressure of the lung itself, PEL. So PA equals PPL plus PEL.
Exactly. That equation describes the forces acting on the alveoli at any point in time, assuming no airflow. PEL represents the pressure generated by the lung's own elasticity trying to collapse it.
And because we define transpulmonary pressure, PL, as PA minus PPL,
it elegantly follows that PL must be equal to PEL, the elastic recoil pressure. PL plus PL, PPL plus PEL, PPL plus PEL. What this fundamental equation tells us is that the pressure difference across your lung is the elastic recoil pressure. It directly reflects how much the lung is stretched and wants to snap back. Understanding this is key to interpreting pressure-volume relationships.
Okay, that makes sense. Let's shift our focus now to a concept we've touched on, lung compliance, or CL. This is a really crucial measure of your lung's elastic properties. Essentially, it tells us how easily your lung can be stretched and filled, right? Is it like a super stretchy, easy to inflate balloon, or more like a stiff old inner tube?
That's a great analogy. Lung compliance is precisely defined as the change in lung volume you get for every 1 centimeter of water change in the distending pressure, which is the transpulmonary pressure, PL. The units are typically milliliters or liters per centimeter of water, LCM H2O. If you have high compliance, your lung is readily distended. It's that easy to inflate balloon. If compliance is low, we say you have a stiff lung, meaning it's not easily stretched.
And the formula is just change in volume over change in pressure. Delta V over delta P.
Correct. CL equals AVPL. For a normal human lung, compliance is typically around 0.2 liters per centimeter of water, measured in the tidal breathing range.
Now, here's a nuance that's important for a truly deep understanding. Lung compliance actually varies with lung volume. You mentioned the curve flattens at high volumes.
Exactly. Your lung is less distensible, less compliant when it's already quite full, near TLC. Conversely, it's also less compliant at very low volumes, near RV. It's most compliant in the middle range, around FRC. That's why, for more precise comparisons, especially between lungs of different sizes, we sometimes talk about specific compliance, which is compliance divided by the lung volume at which it was measured, usually FRC. This normalizes the measurement.
Okay, that makes sense. But you mentioned it's not often measured clinically.
That's right. Measuring true lung compliance accurately requires measuring transpulmonary pressure, which means estimating pleural pressure. This typically involves placing a thin balloon catheter into the esophagus, which sits right behind the trachea and reflects pleural pressure changes reasonably well. It's somewhat invasive and not routine, so we often rely on other PFT measures that indirectly reflect compliance changes. By measuring the volume change in the lung and the corresponding change in esophageal pressure, OPLO as a surrogate for PLO, we can calculate compliance.
This brings us back to that fascinating phenomenon you see when plotting these pressure volume measurements. Hysteresis. You said the curve plotting volume against pressure during inflation isn't the same as the curve during deflation. They form a loop.
Yes, hysteresis. Imagine you inflate the lung slowly up to TLC, plotting volume against transpulmonary pressure, and then deflate it slowly back down, plotting again. You'd find the deflation curve lies above the inflation curve, meaning at any given pressure, the lung volume is larger during deflation than it was during inflation.
Why the difference?
This hysteresis is a critical concept, and it's primarily caused by the behavior of pulmonary surfactant at the air-liquid interface within the alveoli. We'll dive into surfactant next, but essentially it reduces surface tension more effectively as the lung deflates than when it inflates. Think of it like this. It takes extra energy to overcome surface tension and recruit collapsed units during inflation, but once open, they deflate more easily along a different path. By convention, for static compliance measurements, we usually rely on the deflation curve because it better reflects the passive, elastic properties of the already recruited lung tissue without the dynamic influence of airway resistance or initial recruitment.
And looking at that deflation curve, you can visually see how compliance, which is the slope of the curve, changes, right? It's steepest in the middle range and gets flatter, less steep, at high and low lung volumes, indicating lower compliance there.
Precisely. You can calculate compliance as the slope between any 2 points on that curve.
The clinical implications of lung compliance are profound, aren't they? It's affected by several respiratory disorders, offering crucial diagnostic insights. Take emphysema, for instance, an obstructive lung disease characterized by the destruction of the alveolar walls and loss of elastic tissue.
Right. In emphysema, the lung actually becomes more compliant, sometimes abnormally high. Because it's lost much of its elastic recoil, it stretches very easily. For a given increase in pressure, the volume increase is greater than in a healthy lung. It's like an old, overstretched rubber band that has lost its snap floppy, but doesn't return well.
Okay, so high compliance isn't necessarily good.
Not at all in this case. In stark contrast, consider pulmonary fibrosis, a restrictive lung disease. Here, there's excessive deposition of collagen fibers in the lung tissue, making it stiff and scarred. The lung becomes less compliant or stiff. For the same change in pressure, the volume change is much less. It's like trying to inflate a thick, rigid balloon.
So if your lung has low compliance, like in fibrosis, it takes a huge amount of effort, much larger changes in pleural pressure generated by your muscles, just to achieve a normal tidal volume. Instead of a relaxed, easy breath, it's a constant energy-draining fight for every single inhale. That must dramatically increase the work of breathing.
Absolutely. A low compliance significantly increases the metabolic cost of breathing, leading to shortness of breath and fatigue. Understanding compliance helps us grasp the mechanical burden on the patient.
Okay, so beyond the lung's own elastic tissue, you mentioned another major force influencing compliance and lung mechanics, surface tension. This is a hidden but incredibly powerful force at play in the tiny air sacs, the alveoli.
It really is. You can actually see its impact experimentally.
Yeah.
You take an excised lung and inflate it first with saline solution, filling the alveoli with liquid, and then inflate it with air, you'll find it takes much higher pressure to inflate the air-filled lung to the same volume.
Why is that?
The difference is the air-liquid interface present in the air-filled lung. Water molecules at this interface are strongly attracted to each other, creating a force that pulls the surface inwards, essentially trying to minimize the surface area. This is surface tension. In the saline-filled lung, there's no significant air-liquid interface, so surface tension forces are negligible. The difference in inflation pressure is almost entirely due to surface tension in the air-filled lung.
So surface tension acts like an additional force trying to collapse the alveoli.
Exactly. It adds to the elastic recoil of the tissue itself. And for the alveoli, which are roughly spherical, this force has critical implications governed by Laplace's law. Laplace's law, applied to a sphere, states that the pressure inside the sphere needed to keep it open. PS is directly proportional to the surface tension, T, of the liquid lining it, and inversely proportional to the sphere's radius. The formula is PS equals 2TR.
Inversely proportional to the radius, so smaller spheres have higher pressure.
Correct. For a constant surface tension, smaller alveoli would require higher internal pressure to stay open compared to larger alveoli.
Now, here's where the truly miraculous part comes in. The role of pulmonary surfactant. You mentioned this earlier. Your alveoli are lined with this substance, mostly lipids, and it's a total game changer for breathing.
It's absolutely essential. Surfactant has several critical physiological roles. First, as we've hinted, it drastically reduces the work of breathing by lowering those surface tension forces at the air-liquid interface. Much less pressure is needed to inflate the lungs. Second, it's vital for preventing the collapse and sticking together of alveoli, especially smaller ones, during exhalation when lung volumes get low. And third, it acts like a stabilizer, helping to keep alveoli of different sizes stable and preventing air from just emptying out of small ones into large ones.
Let's unpack that stability point. If we didn't have surfactant and surface tension was constant like plain water.
Well, thinking like an elite professional requires understanding this consequence. Based on Laplace's law, PS equals 2TR, if surface tension T remained constant, smaller alveoli, smaller r, would have higher internal pressure, PS, than larger ones, larger r. This would create a profoundly unstable situation. Air would naturally flow down the pressure gradient, moving from those small, high-pressure alveoli into the larger, lower-pressure ones.
So the small ones would collapse and the big ones would get even bigger.
Precisely. The inevitable result would be widespread collapse of small alveoli, atelectasis, while the larger ones would overdistend and potentially rupture. It's a recipe for inefficient gas exchange and lung injury.
But surfactant is brilliantly designed to solve this problem. How?
Surfactant has a unique and remarkable property. Its ability to reduce surface tension is not fixed. It changes dynamically with surface area. Specifically, as the alveoli stretch and surface area increases during inhalation, the surfactant molecules spread apart and surface tension rises somewhat, though still much lower than water. Crucially, as the alveoli shrink and surface area decreases during exhalation, the surfactant molecules become more concentrated, packed tightly together, and they reduce surface tension dramatically, down to very low levels.
So it lowers tension more when the alveolus is small.
Exactly. This dynamic modulation means that as alveoli get smaller, the reduction in Laplace's law is counteracted by a much larger reduction in T. This helps to equalize the pressures between small and large alveoli, stabilizing their volumes and preventing that catastrophic collapse of small units and overdistension of large ones. It's an incredible feat of biological engineering, a self-regulating system ensuring alveolar stability.
Where does this amazing stuff come from?
This vital pulmonary surfactant is synthesized and secreted by specialized cells lining the alveoli called alveolar type 2 cells, or type 2 pneumocytes. It's stored within these cells in unique structures called lamar bodies, which look like layered onions under a microscope. It's then secreted into the thin liquid layer lining the alveolar space, initially forming a structure called tubular myelin, which then spreads out as a monolayer at the air-liquid interface.
And what's it made of? You said mostly lipids.
Yes, its composition is mainly lipids, about 85% to 90% by weight, mostly phospholipids. The rest, about 10-15%, is specific surfactant-associated proteins. The primary phospholipid, making up 70-80% of the lipids, is phosphatidylcholine, and a large fraction of that, maybe 75%, is a specific saturated form called dipalmitoyl phosphatidylcholine, or DPPC. DPPC is the key component that allows surfactant to achieve those extremely low surface tensions when compressed. Another important phospholipid, phosphatidylglycerol, PG, making up maybe 110%, is crucial for helping the surfactant spread out effectively across the surface. There are other minor lipids too, like cholesterol.
And the proteins, SPA, B, C, D.
Right. There are four main surfactant proteins. SPA and SBE are larger hydrophilic proteins involved in surfactant metabolism, structure, like forming tubular myelin for SPA, and importantly, in innate immunity within the alveolus, helping to fight off microbes. SBB and SBC are smaller hydrophobic proteins that are absolutely essential for the surface tension lowering properties and the spreading of the lipid film. SPD in particular is critical. Mutations in its gene are lethal without transplant. They integrate with the lipids in the model layer.
So how is surfactant production and removal controlled?
Surfactant is secreted from the type II cells via exocytosis of those lamellar bodies. This secretion can be stimulated by various factors, including lung inflation, stretching the cells, and certain signaling molecules like beta-adrenergic agonists related to adrenaline and purinergic agonists like ATP. Once it's done its job in the alveolus, it needs to be cleared. Much of it is actually taken back up by the type II cells for recycling, which is very efficient. Some is degraded by alveolar macrophages, and a small amount might be cleared via the airways or lymphatics.
But you mentioned it can be inactivated.
Yes, and this is a critical clinical point. Surfactant function can be severely impaired or inactivated by various substances that might enter the alveolar space. Think about conditions like pneumonia or acute respiratory distress syndrome, ARDS. If protein-rich fluid from edema, blood components from hemorrhage, or inflammatory mediators leak into the air spaces, these substances can interfere with the surfactant film, displacing it or inhibiting its function. This inactivation increases alveolar surface tension, making the lungs stiffer, decreasing compliance, promoting alveolar collapse, and profoundly increasing the work of breathing. It's a key part of the pathophysiology in many severe lung injuries.
That sounds like a dangerous, vicious cycle.
It absolutely can be.
Now, beyond surfactant, is there anything else that helps keep alveoli stable?
Yes, there's another important mechanism contributing to alveolar stability, especially preventing regional collapse. Alveolar interdependence. Most of your alveoli, except for those right on the very surface of the lung next to the pleura, are not isolated bubbles. They share walls with their neighbors. They form this interconnected honeycomb-like structure.
Like a foam.
Exactly like a foam. And this structure provides inherent mechanical stability. The tendency of one alveolus to collapse is strongly resisted by the physical pull or traction exerted by the shared walls of its surrounding inflated neighbors. If one alveolus starts to collapse, it stretches and distorts the walls it shares with its neighbors, and that outward pull from the neighbors helps to hold it open. This mechanical tethering spreads the stress throughout the network.
So they support each other.
Precisely. Adding to this stability are tiny connecting pathways between adjacent airspaces. Pores of Kohn are small openings directly through the walls linking adjacent alveoli, and canals of Lambert are small channels connecting the very small terminal airways, bronchioles, directly to nearby alveoli. Both of these provide routes for collateral ventilation, basically. Air can take detours between lung units. This is crucial because if one small airway gets blocked, air can still reach the alveoli downstream via these collateral channels, helping to prevent that section of the lung from collapsing, what we call atelectasis or absorption atelectasis.
Fascinating, like having bypass routes built in. In the clinic, the profound importance of surfactant is perhaps nowhere more dramatically seen than in premature infants, right? With hyaline membrane disease, or HMD, now often called respiratory distress syndrome of the newborn.
Yes, absolutely. HMD is a critical condition, historically responsible for many deaths in premature infants. It's caused directly by a developmental insufficiency of surfactant production by their immature type II cells. Specifically, they often lack sufficient amounts of that crucial phospholipid, phosphatidylglycerol, PG. Without adequate surfactant, their alveoli have very high surface tension, leading to widespread collapse at the end of exhalation, very low lung compliance, stiff lungs, and tremendous work of breathing just to inflate the lungs with each breath.
But the incredible news is that decades of research have led to effective treatments.
It's one of the great success stories of translational physiology. The development and use of exogenous surfactant replacement therapy, giving artificial or animal-derived surfactant directly into the infant's lungs via an endotracheal tube shortly after birth, has dramatically improved survival and outcomes for these premature babies. It's now standard, life-saving care worldwide.
That's amazing. And we can even help before birth.
Yes. Another major advance is the use of antenatal corticosteroids. If preterm delivery seems likely, administering steroids like betamethasone to the mother a day or two before delivery can actually accelerate the maturation of the fetal lungs. The mechanism is fascinating. The steroid crosses the placenta, enters the fetal circulation, reaches the fetal lung, and binds to specific receptors in the type 2 pneumocytes. This binding stimulates the cellular machinery, increasing the transcription of genes for surfactant proteins and enzymes involved in phospholipid synthesis. Essentially, it gives the fetal lung a boost to start producing its own surfactant earlier and in greater amounts.
It's a remarkable example of how deeply understanding these fundamental mechanisms of pressure, volume, compliance, and surfactant biology translates directly into real-world life-saving interventions.
It truly is.
So what does this all mean for you now that we've taken this deep dive? We've journeyed through the intricate world of static lung and chest wall mechanics, really understanding how every single breath you take is a masterful, finely tuned balance of pressures, volumes, and elasticity. From that subtle dance of alveolar and pleural pressures that pulls air in and pushes it out, to the careful measurement of lung capacities using clever techniques like plethysmography, and the absolutely incredible life-saving work of pulmonary surfactant maintaining alveolar stability, it truly is a marvel of biological engineering.
Stepping back to see the broader implications, it powerfully underscores just how interconnected and, frankly, delicate our respiratory system is. Even a seemingly subtle imbalance in elastic recoil due to disease, or a disruption of surface tension from infection or injury, can profoundly impact the work of breathing, leading to significant disease and real challenges for a patient's daily life. This detailed understanding is exactly what elite professionals use to diagnose and manage respiratory conditions. And it naturally makes one wonder,
It does, doesn't it? Thinking about all these incredibly complex, finely tuned mechanisms, the specific properties of the elastic fibers, the specialized type 2 cells, churning out that dynamic surfactant mixture, those precise pressure gradients maintain breath after breath, the structural resilience from interdependence, and the constant dynamic adjustments needed really makes you wonder. Could we ever truly replicate this biological complexity outside the body? What would an artificial lung designed truly from scratch need to account for beyond just the basic gas exchange surface to genuinely mimic these crucial static mechanical properties, the compliance, the stability, the FRC balance for long-term, sustainable viability? It's something to mull over as you consider the incredible deep dive of mechanics happening inside you with every single breath.